Thank you for joining us for our first mock oral session of the season. I'm really pleased to introduce our two examiners for tonight. First off, we have Dr. Jason Chen, who's joining us from the Bay Area. He's currently a practicing community colorectal surgeon at the Permanente Medical Group, Kaiser Walnut Creek. He completed his general surgery residency training at Georgetown University Hospital in Washington, D.C., and colorectal surgery fellowship at the University of Southern California. He loves to teach medical students and residents and won the President Gold Award as the chief resident who exemplified the model of clinician educator. Having been one of the mock interviewees for us a few years ago, he knows that he feels honored to be asked to be a mock interviewer. He currently teaches UCSF East Bay general surgery residents and California North State University medical students. Our other examiner also hails from sunny California, Dr. Marjan Doodle. He completed his general surgery training at Loma Linda University Medical Center and received his colorectal training in New York at the New York Presbyterian Weill Cornell Columbia Presbyterian Medical Center and Memorial Sloan Kettering Medical Center. And he is currently faculty at the Keck School of Medicine at the University of Southern California. For our three examinees, thank you so much for volunteering your time. We really appreciate it. And we hope that this session is useful for all of you. And I will be asking for your addresses so we can send you a gift from the CRS Virtual Education. We know that it is, we value your time and also really value you being willing to kind of go through this live with us. So first is Dr. Modi, who is a colon and rectal surgeon working at a community hospital. And we also have Dr. Peroni, who is completed his colorectal surgery fellowship at Creighton and then returned to Stanford, where he is currently a clinical instructor, and Dr. Pierre, who is also currently working as a colon and rectal surgeon. Thank you all for joining us, and I will be quiet and let our mock orals begin.
Thank you, Joyce, very much for that introduction. It's a pleasure to be again met up with Dr. Chen. It's been a little while since we've last seen each other and anything, but it's always good to continue the education of our colorectal fellows who have completed their training and are preparing for their board examinations. Do you want to start out with your first scenario, Jason, or do you want me to start out?
Yeah, I'm happy to go. All right, so who's up? Who do I have the pleasure of interviewing? Dr. Modi?
Sure, why not?
Okay, great. So we'll go ahead and get started. So you're in clinic and you have a 70-year-old man with a history of hypertension, hyperlipidemia, diabetes, coronary disease, active smoker, who presents with a few months of nausea, intermittent abdominal pain that's improved with reflux, and he's noticed some abdominal distension, 10-pound weight loss. Never had a prior colonoscopy, no family history, inflammatory bowel disease, or colorectal cancer. He comes to your clinic and he's afebrile, his heart rate's in the 70s, and he's setting 99% on room air. He's not in any distress, he's not labored, and is breathing. But his abdomen is, even though it's soft, it's grossly distended and tympanitic, non-tender, no scars, masses, or hernias. Digital rectal exam is negative for any rectal mass. Tell me how you'd like to proceed.
Most of the history is given to me. I've got a 70-year-old male with seems like to have some bowel obstruction. Is not ill or distressed right now. I'll ask some more clarifying questions regarding his family history, if I missed that, and then his bowel habits, and if any recent change in bowel habits.
Yeah, so family history is negative for anything concerning, but his bowel habits, you've noticed intermittent loose stools and mixed with constipation. He says he's been more and more constipated, and when he does poop, it's small volume and often loose.
Yeah, so this is a 70-year-old male who has got intermittent bowel obstructions and recent change in bowel habits with weight loss. I'm concerned for malignancy or colitis, other kinds of stuff that can be causing his bowel obstruction. So I'll start by sending him to the ER at that point of time, just because he's distended and is nauseous, and then start with getting a KUB, some blood work, start some IV fluids and then get some labs, CBC, CMP, electrolyte, coagulation panel, and if possible on the if the KB doesn't show any free or anything like that, then I'll get a CT scan with IV contrast, abdomen, pelvis.
Great. So your white count is 8, hemoglobin 14, creatinine 0.9, and the ED just goes straight to getting a CT scan, which I'm going to bring up. And I'll just show you one representative image. Let's see if you can see it. Can you see my screen?
Just right now. Yeah, some dilated, it's like dilated bowel all over. I see, I can't figure out where the colon is, just the dilated bowel all over. And then I see there's a transition point somewhere in the pelvis.
Yeah, so
right here.
Yep. Good. So I'll just point out the radiologist does read it and says there's a hairpin turn in the proximal sigmoid colon and decompressed distally, and like you said, distended large and small bowel fecalization within the small bowel.
Okay.
And then there's also this, we also mention a hypodense irregular lesion in the liver concerning for metastatic disease that you can see here. And otherwise his vitals are fine. He's gotten some IV fluids. And they mentioned that the hairpin turn here is concerning for malignancy. So tell me your next move.
All right. So this patient has presentation of this looks like malignant lesion and which is causing obstruction. So it's symptomatic. I'll send CEA and then hemoglobin 14, and I'll consent him for exploratory laparotomy, resection of this area with an oncological fashion so that it can relieve his obstruction. But prior to proceeding with surgery, I will also put an NG tube to decompress him, although I don't see in this limited X-ray or CT scan that there's a distension of the stomach, but I'll still place an NG to prevent aspiration during induction. And while I'm in the OR, I will start with diagnostic laparoscopy and then try to do this laparoscopically, but since the bowel is distended, I'll have low threshold to convert to open.
What operation are you consenting him for?
Exploratory diagnostic laparoscopy, exploratory laparotomy, bowel resection, possible stoma, most likely glioblastoma. And if I can do a liver biopsy of that lesion, I will also do a liver biopsy of lesion. I'll also get some EKG, and I don't know how much that will help, but just because you said he has CADs, hyperlipidemia, hypertension, and smoker, just to make sure he doesn't have any active cardiopulmonary distress going on, which didn't seem like on the physical, but we get the EKG.
Okay, great. So you go in and you take them for, you try laparoscopy, but it was like very little space, so you decide to go straight open. And inside you find grossly dilated bowel, you find the mass. You don't see any surface malignancies, but you are able to, you notice there's some bulky lymph nodes in the mesentery, and you do resect the sigmoid colon, and you bring up an ostomy. And you don't, because you can't see the liver, there's nothing for you to easily biopsy. And you close the skin, and it goes well and does well. So tell me, after the surgery, he's recovered in the post-op care. He's tolerating diet. He's had his ostomy teaching. Tell me about your management afterwards. He's tolerating his diet. He's having good bowel function. He's going home. What's your plan afterwards?
I'll wait for his pathology, and then also send. Hopefully, they also do MMR on that pathology. In the meantime, I will consent him for a completion colonoscopy after 3 months, and also get an MRI abdomen for that liver lesion, and consent him, if that's concerning, for a percutaneous biopsy to assess that whether this is a stage 3 or a stage 4 colon cancer, based on pathology, likely a colon cancer.
Oh, great. So you said, I heard colonoscopy, MRI of the abdomen. Was there anything else you wanted?
I had ordered a CEA prior to proceeding to the OR, so hopefully that is back, and the pathology review. Pathology is not back, so I'll wait for the pathology as well.
Okay, great. So let's say pathology comes back, it's MMR proficient, and it's adenocarcinoma, moderately differentiated, and there's 10 out of 20 nodes positive for cancer. He gets a colonoscopy, like you said, there's no other lesions. He gets an MRI at the abdomen, it is concerning for liver metastases. What would you do next?
I'll get a biopsy of one of those liver lesions just to prove that it's a stage 4 colon cancer. Since it's only limited to on the right side of the liver, so it's oligometastatic disease, I'll start with adjuvant chemo, discussing the tumor board, but likely adjuvant chemotherapy after 3 or 8 weeks of surgery.
Great. So let's change the scenario a bit, and let's say you go in and before you do your resection, you're running the bowel and you notice that the cecum is actually massively dilated and thinned out, and you see some serosal tears, but it's otherwise pink, it's viable, but you see some serosal tears. How do you want to manage this operation?
Yeah, I will perform a right colectomy as well, and will anastomose both the colon and if I can, and bring out a diverting loop in this case. So that will divert both the anastomosis.
Okay. And I want to change it up again and say, let's say this time, the imaging, the CT shows that you have a mid-upper rectal mass concerning for malignancy on the CT. How would you manage the case if we go back to the beginning? We're in the ED, he's again stable, vital signs are stable, labs are not concerning, but he is grossly obstructed from a mid to upper rectal cancer.
Well, in that case, if I have GI facility available, I can always try to get that stented because it's a mid-upper rectal tumor. They should be able to put the stent. If not, then obviously then I have a chance to take him to the OR to do a diverting loop sigmoid colostomy to relieve his obstruction. One of those will be the two options. And then I'll send him for new adjuvant chemotherapy. And
okay, so you said either stent or diverting colostomy?
yes, sir.
And then after he recovers from that, let's say he gets a diverting colostomy.
Yes, sir.
And he recovers. What are you going to do after that?
Yeah, I'll do a flexible sigmoidoscopy, get a biopsy, make sure it's a tumor diagnosed, and then also get the MRI abdomen to get the liver mass also diagnosed at the same time. And considering if they both come as adenocarcinoma, then into a stage 4 disease, oligometastatic, I'll send him, discuss in tumor board, and then most likely send him for new adjuvant chemotherapy.
Great.
To convert to resectable. The goal of converting the disease to resection.
Great. So I'm good with stopping there. Shall we go ahead and go over some of these things? Okay. So just a time check. I think we have about 5 minutes. But basically, I think overall, you have good composure, which I like. You kept calm, and that's very good. Some of the things that for the first part of the case, before going in for the surgery, when they're this grossly distended, and you're very likely to go divert or create an encolostomy. I didn't hear you say mark the patient, and I think that's really important to say. Do you recall saying that? Maybe you did.
No, I did not say. I did not say. Yeah,
okay.
I should have done that.
Yeah, so
which I do really in my practice, but I didn't say it.
Okay. Yeah, because you can cause a whole world of hurt if it's not in the ideal location, if it's in a fold or too close to the ribs, too low. And then regarding the staging, regarding the workup at some point afterwards, after stabilizing the patient after the surgery, I don't recall you saying CT chest to look for lung mets. Maybe you did, but don't forget to say that. But following up on the path, getting a completion colonoscopy, that's all very important. And referring to med-onc to discuss adjuvant chemotherapy, that's all very important. And then regarding some of the other scenarios, the serosal tears, I think a right hemi and anastomosis, that's an option. You can also do a subtotal, the endoleostomy, that's another option. I think it's fair the way you described it. But this guy hasn't been eating well. Yeah, you diverted, which is right. I'd say you definitely want to divert because he's been not eating well. He's had weight loss, smoker, bad vascular disease. And then finally, regarding the upper rectal scenario, mid to upper rectal scenario, I think stents, if your institution does them frequently, I think it's reasonable. But I feel like with rectum, I feel like it's especially with mid rectum, it tends to hurt and is very uncomfortable for the patient. So my preference is different colostomy. I'm glad that you did the FlexSig to diagnose this. But again, I don't remember you saying CT chest. And then I don't also recall you saying getting an MRI afterwards to look at the pelvis specifically. And that's pretty critical to stage the local regional disease burden, just to have an idea before tumor board. But I like that you talked about TNT and tumor board discussion to continue his treatment.
The comment I have about GI stenting is quite often what they'll say is GI is not available. So how are you going to stent the patient? And so unless you have a lot of familiarity with it, I'd probably mention basically what your strengths are in your procedures. If you've done a couple of them in your practice, and some
Yeah,
people have actually, you go ahead and make that straightforward and make that part of your wheelhouse and make that part of your algorithm for treating malignant bowel obstruction. But just be mindful, anything that you mention is sort of like, fuel for any sort of like further questioning, and you just can't necessarily rely on other services. It's quite common. This is a quite common scenario. You're gonna get a colon cancer or rectal cancer, you're gonna get a diverticulitis. All of this you guys are already familiar with this because you've been practicing as a colorectal surgeon already. And so there's not going to be any surprises. So you just got to have your sort of algorithm down, sort of on track, and just be firm with it because this is what you do and this is what you do in your best practice. With that being said, so who wants to go with the next scenario? Dr. Pierre? All right, volunteered. So you have a 38-year-old male who presents with a fourth episode of left lower quadrant abdominal pain. He's been seen intermittently at the ER nearby your office about 4 times and mainly been treated with antibiotics. He was told that he does have a history of diverticulitis, but he was referred to you because on the last CT scan that he presented with to the ER showed some air in his bladder. Currently, he's afebrile, vital signs within normal limits. He has no prior family history of colorectal cancer. His social history is positive for prior smoking, but otherwise, no other medical problems, no other prior procedures. He does note that more recently he's starting to develop some air when he urinates, typically at the very end of the stream, with some dysuria associated with that. He denies any prior treatment for urinary tract infection. No prior colonoscopies, like I said, no prior surgical history, no medications or allergies. How would you like to proceed?
Okay. Sounds like you have given me pretty much most of his medical history, but I do want to know in regards to his fourth episode of diverticulitis, how frequent in the sense in the last 4 years, the last year, couple months, and the severity of all of those associated episodes.
Sure. And his first episode was approximately 4 years ago. It was during a birthday party. But then the last 3 episodes have been within the last year. The most recent one before that was about a month and a half before his prior episode, for which he said that was the second time that he was treated with antibiotics.
Okay. So I would want to know, aside from the air that he's passing through his urine, has he noticed any fecal matter or any debris within his urine, any blood associated with it as well? Also want to know if he's had any associated rectal bleeding with all of this.
So he denies any rectal bleeding. He denies any darkening of stools. He does note that there's a little bit of a cola colored in his urine on occasion, but otherwise no blood that he's noticed or debris.
Okay. So I'd want to go ahead and do an abdominal exam, a focused exam to include an abdominal exam, as well as an anal rectal exam, and see kind of a understanding what from that standpoint.
Okay. Abdominal exam shows some mild tenderness in the left lower quadrant with what you may sense as a sort of mass phlegmatous change on deep palpation, but otherwise no scars, no hernias that you can appreciate. No real guarding. Vital signs, like I said, within normal limits. Before on digital rectal exam demonstrates normal anal tone. Unable to feel a mass. You feel a smooth prostate. Otherwise, and let's see, some mild hemorrhoids, but otherwise nothing really remarkable.
Okay, so I did discuss with the patient that it looks like he has a complicated diverticulitis with diverticular disease, currently with signs of colovesical fistula. So discuss with him proceeding with a colonoscopy, one to also to evaluate his colon, make sure that to screen his colon, but also to ensure that there are no signs of associated malignancy, which could also present as a colovesical fistula. And go from there. I would want to go ahead and get some basic lab, CBC, BNP, and set him up for a colonoscopy.
Sure, he preps for a colonoscopy. Your labs on review demonstrate basically a mild elevation in white count of like 11, but otherwise electrolytes are within normal limits, normal creatinine as well. And you do his colonoscopy, you notice basically moderate sized diverticulum within the sigmoid colon, approximately from 25 centimeters, distally to approximately about 45 centimeters proximally, all within the redundant portion of the sigmoid colon. No other mass lesions or polyps noted. What else would you like to do?
I would want to also I discussed with him the findings of his colonoscopy. And although an obvious fistula wasn't seen on the colonoscopy itself, his previous CT findings does note the air which is consistent with it. We could do a CT urogram to confirm whether there is obvious fistulous tract. But with those findings, I would recommend or discuss with the patient the option of proceeding with a elective sigmoidectomy with a colovesical fistula takedown.
So did you want to do the cystogram first, or do you want to go to the surgery?
I typically just proceed with the surgery as the recent CT is confirming me as well as his physical exam, his signs and symptoms.
Okay. What are you consenting your patient for?
So I would plan to consider him for a laparoscopic sigmoidectomy with a colovesical fistula takedown, possible bladder repair. I would also include the possibility that I'd have to convert to an open procedure, as well as a possible ostomy. I would involve my urology colleagues in the beginning to plan for ureter stents or ICG injection at the time of the surgery.
What's your criteria for inserting ureter stents?
My criteria particularly would, for this patient, patients who have a history of significant diverticular disease and concerns that there is inflammatory process. Typically, it would be in a situation like diverticular disease. Typically, I wouldn't request stent placement for patients who may have early sigmoid colon cancer or haven't had any truly inflammatory process that would make it difficult for the dissection.
Okay. So you got the patient back into the operating room. You're performing a laparoscopic sigmoidectomy. You have your ports placed. What you observe is that there is a dense phlegmon in the anterior pelvis to the dome of the bladder, but also phlegmonous reaction that extends down towards the left pelvis. And how do you do describe to me your details in regards to, you see that sort of situation, how you would proceed with your procedure?
So I would initially start my dissection in an area likely in the at the level of the descending colon, where the planes may not have been violated by the inflammatory process, and essentially work around the area in which I am able to mobilize the colon and its mesentery where there is not significant amount of inflammatory tissue. And then once I am able to kind of chisel away any of that tissue and separate the phlegmous mass from the bladder, and subsequently taking the mesentery close to the bowel wall so that I can free up the bowel and making sure that I identify the ureter. I would kind of work in that fashion to completely mobilize this, the specimen itself.
Let me actually stop you, like have you hold that right there. Let me say you're doing your dissection and you're looking for that left ureter. You can't find it. What do you do?
So then I would first probably reach out to my urology colleagues and see if they could perform a cystoscopy and and see if they can help identify the ureter with injection of contrast.
Okay. So urology is about 3 hours away. They're in their own sort of cystectomy. Unfortunately, that's how these scenarios go. You're doing, from my understanding, a medial to lateral dissection starting at the pelvic brim. You can't find the ureter in that area. Can you tell me other locations where you could find the ureter?
I could go ahead and I could attempt to lateralize the the colon, taking down the sigmoidal attachments as well as the lateral attachments, and medializing the colon to see if I can identify the ureter from that standpoint.
Okay, so you do a lateral to medial dissection. Are you doing this laparoscopically or are you doing it open?
So at this point, if I'm concerned about identifying the ureter, and I would open just to make sure that I can accurately feel for the ureter or at that time.
Okay, so you still get it to that point. You basically have it lateralized from the splenic flexure all the way down to the pelvic brim where that phlegmon is. Still can't find it.
Okay, so then I would go ahead and essentially backfill the bladder and with a methylene methylene solution of saline to see if we can have it backflow into the left ureter for identification.
Great. So you do that backflow, and you're noticing that there's a little bit of clear blue fluid in your pelvic dissection, and you do identify a spaghetti-like object that is hollow tube in nature and about a 3 millimeter rent in the left ureter. What do you do? Presumably, probably injured from like bovie dissection or something or other.
Okay, so at that point, I would want to once again see if my urologist was available for placement of a J stent, and then essentially J stent, and excuse me, you said a rent or a
Yeah, 3 millimeter sort of rent in the ureter with some leakage.
Okay, so I want to go ahead and see if I can get a J stent placed past that area, and then I want to see if I could oversew that rent and would plan to leave a drain in place as well as a Foley catheter.
Great. Okay. So you do your primary ureter, and you're able to complete the rest of your operation. All as fun as all these diverticulitis operations are, do you do a primary anastomosis? Are you diverting this patient?
Well, with him, I had planned for an elective procedure as long as there was no obvious fecal contamination and the tissue itself appeared healthy and without inflammation. My plan would be for a primary anastomosis.
Okay. Do you do anything with your primary anastomosis?
So yes, once I create my primary anastomosis, I would perform a leak test. I typically also do a flexible sigmoidoscopy at that time.
Okay, no leak noted on the flexible sigmoidoscopy. Your patient makes it out of the operating room. No diverting ostomy per your description. He actually has return of bowel function on postoperative day number 3, but then he comes to your office post-op day number 9, complaining of fever, no dysuria, no fecal uria or pneumaturia, but increased lower abdominal pain and some mild tachycardia up to 110.
Okay. So I would, while he's in my office, I would also want to do a focused abdominal exam, just to focus abdominal exam, and given his vitals, plan to have him go to the ER for additional workup.
So he's at the ER now. His vitals are 110, blood pressure soft 100/75. It responds well to fluid. And what is your workup as far as like the ER? What are you asking him to do?
So I would want to go ahead and have him draw up some labs, a CBC, a BNP, as well as coags. And I'd also want to get a CT of his abdomen and pelvis, assuming his creatinine level is could tolerate IV contrast.
Okay. Creatinine is not terribly elevated, less than 1. You do the CT with IV contrast, and it basically shows a low pelvic fluid collection, approximately 4 centimeters in size. And, no gross free air, but there are some air bubbles around the area of your anastomosis. How would you like to proceed?
Okay, this looks like he has a delayed presentation of likely a anastomotic leak now with a associated abscess. So I would have him admitted to the hospital, start him on IV antibiotics as well as continue with the IV fluids. I would also plan to discuss with the interventional radiologist the option of percutaneous drainage given the size. And I would initially keep him in PO for the planned procedure.
Okay. So let's actually change the scenario a little bit. And the CT scan demonstrates gross free air and basically, a large fluid collection in the pelvis. How would you manage that patient?
So I would plan to actually take him to the operating room. I will discuss with him prior to that this appears to be an obvious leak or disruption of his anastomoses, and that I don't think draining it would be an option for him, especially given his presentation, and that I would plan to not only address the problem, but we would have to proceed with a end colostomy as opposed to actually creating a primary anastomosis.
Sure. So you do your end colostomy, you take him to the operating room. What's your plan in reversing this guy?
So ultimately, after he's recovered, I would wait probably about 6 months prior to proceeding with reversal. I would initially work up him by doing a gastrograph and enema to assess that rectal stump. And then I would have a discussion with him, the plans of primary closure, but would also plan a diverting loop ileostomy at the time of the colostomy closure.
Great. Actually, I think you did very well in that scenario. Any questions in that regards?
I'm trying to think.
Yeah, so quite commonly with the diverticulitis ones, the other scenarios would be like how to manage your ureter complications, because urology is going to be out of the way. I know that we don't expect you in actual real practice, we don't expect you to be the one to be doing the urologic repair, the ureter repair, but it's good to keep things sort of on hand so that basically you can sort of run it off like a, small rents or small injuries less than a centimeter. You could try primary anastomosis. If it's very close to the pelvic brim, you could think about doing a biliary flap, all that sort of thing, because you're going to be messing around with the dome of the bladder anyways. You could probably anastomosis there, neoureterocystostomy in those sort of scenarios too as well. But it's just good to have those sort of things on hand. The other scenario is I could have probably kept going on and basically see how you manage your post-diverticulitis patient after urology repair. That has been one scenario, but I wanted to go to another more common scenario, which is anastomotic leaks. You're going to get a leak somewhere, and it's going to be crazy. And such. And so managing it non-operative versus operative is basically the two standards that we try to get you to go and everything. So I think you handled that otherwise pretty well. And anything, you kept very good composure. I would just probably think about those sort of scenarios where basically, yeah, what is your criteria for taking this patient to the operating room? Just list it off right there so that I don't have to like kind of egg you on a little bit. But also in regards to the urologic repair, just know something. And that way, when the urologist comes repair, and I would even still say, yeah, have the urologist come in, do a retrograde cystogram to make sure that my leak is, everything is good. And the other thing I didn't ask you is how you'd repair your bladder after you take down you do your sigmoidectomy. But, be prepared for that sort of scenario. But yeah, fun. You want to hit us with the last one there, Jason?
Yeah, and just to add to that, I don't know, I'm not sure if you mentioned it, but did you say you did like a bladder leak test where you insufflate? That's probably a good thing to think about. Just checking to see methylene blue saline.
Yeah, I think your bladder test, I used your bladder test to identify that you had a ureter injury. So I think that's what I put the scenario through.
Yeah.
So, but yeah,
Yep.
going on Dr. Chen, you should still also leak test your own repair.
Yep.
And then also, yeah, all left-sided stuff, left-sided anastomoses, I do leak checks. If you don't, they may catch you on it, and you got to figure out a way that you do it. You could do it with the flex sig, you could do it with the rigid sig, however it is in your practice, just stick with it.
All right, so I'm okay with good to proceed. Okay, so who do we have next? Is it Dr. Peroni?
Yep.
Okay, great. So let's we'll start off. We have a 64-year-old lady in your clinic. She has a history of actually large bowel obstruction, for which she reports, you looked in the chart, she had a loop colostomy for a rectal cancer, and it was staged as T3N0. She got chemoradiation and then saw a colorectal surgeon who actually ended up doing an APR for her, small bowel resection and vaginectomy to its involvement to all these structures nearby. And so that was all 5 years ago. And she has since had CT scans, surveillance that have not showed anything, no recurrences distantly or within the pelvis. But she does mention that she has frequent, every 4 to 6 months, she has a partial bowel obstruction that she's been having managed non-operatively. But she's in your clinic now because she noticed some green output from her vagina. It's scant, but she's never noticed it before. Doesn't mention any dysuria, no abdominal pain. Still has her vague intermittent abdominal pain. Well, she still has colostomy output. And she's in your clinic. She looks well. Vital signs are stable, afebrile, soft abdomen, and you do a vaginal exam and you look and you see there's looks like some succus in there. You don't see an obvious hole, and the perineal wound looks fine. You don't feel any masses. You don't see any scars. Her abdomen's flat. There's no hernias. She has a pink stoma, slight peristomal hernia. But tell me how you'd like to proceed from here.
So it sounds like I have a fairly complete history. I'd want to review any prior operative records to understand what had previously been done, as well as review any recent imaging studies again to confirm that she doesn't have any evidence of recurrence. And then would also want to talk to her kind of about her symptoms, how long this has been going on for, and also want to understand her any overall infectious symptoms or anything that point me towards malnutrition.
So she's been eating well. She hasn't had any weight loss. And you check her record. She had a colonoscopy through her stoma a year ago, and there was no polyps, no masses. And our last CT scan within the last year did not show anything concerning for malignancy. But you do notice that she had a small bowel anastomosis that looks very dilated, and there's a lot of decompressed small bowel in the pelvis close to the vagina. And that was about 6 months ago.
Okay. So again, I'm concerned that she's developed a fistula to her vagina. I'd want to, at this point, perform an abdominal exam. As you guys have already performed an abdominal exam and a vaginal exam. So we'd want to send her for a CT scan with enteral contrast, again, to further assess.
Okay, great. So you do that, and let me see if I can pull up an image. Tell me if you can see my screen.
Yeah, I can see your screen.
Okay, you can, why don't you just go ahead and tell me what you think you see? I know it's just a snapshot, so go ahead.
So I think I see contrast in the small bowel, kind of with a transition point there, as well as some extravasation into this pelvic fluid collection. And it looks like her bladder is anterior here.
Yeah, so you get the CT read, and it shows there's a transition point into the pelvis of the small bowel dilated upstream with contrast entering the vagina. They don't actually see a fluid collection. And this is the anterior view. See the dilated small bowel. If you look carefully, there's a staple line there, and decompressed small bowel adjacent. So you have this information. What would you like to do? They're saying that there's a enterovaginal fistula with contrast from the small bowel into the vagina. No abscess, and she's not septic.
She's not septic, and this has been going on for several months at this point.
I'll say the succus, the green output in her vagina, let's say has been about a week. It's scant.
Okay. So at this point, I would discuss with her taking her to the operating room for further evaluation, and would plan for a redo of that, takedown of that fistula with a small bowel anastomosis, and ideally would place omentum down into between kind of where my new anastomosis would be and the vaginal cuff.
Okay, so what exactly are you consenting the patient for?
Consent her for exploratory laparotomy, takedown of vaginal small bowel fistula, small bowel resection with possible diverting ostomy and omental flap.
Okay. Any other workup before, any other consults before this?
So it'd be nice to have my gynecologic colleagues involved in this if they're available to assess the vaginal cuff and repair that.
Okay. Let's change the scenario and say that you know, this patient comes to you now. She's got tons of, instead of just scant output, by the time she's seeing you in clinic for the first time, she says she's in a ton of pain, lots of output. She's really tired and weak, and she says it hurts. She has a lot of pain. Everything's raw in her perineum. And so that's how she's coming in. She doesn't say any fevers, just pain and weakness, fatigue, and no blood, low appetite, and the vitals in the clinic. She's afebrile. Her heart rate's 98 at rest. Blood pressure's 98 over 50, and she's in your clinic. You do a vaginal exam. There's just too much succus to see anything besides the succus. She has no masses. Her abdomen is soft. She's not tender in abdomen. She's not distended. No hernias. Her stoma is pink. Otherwise working. But she looks tired and fatigued and ill. She looks weak. She hasn't been eating one. So what do you want to do?
So this is someone who sounds like I'm much more worried about kind of malnutrition, failure to thrive. This is someone I would recommend that she go to the ED for expedited evaluation with further laboratory and imaging studies.
What studies? I'll say she gets labs. She's hyponatremic, 130. Her creatinine's 2. Her hemoglobin's 16. What else do you want?
I want albumin as well as a pre-albumin to assess her nutritional status, and then the CT scan.
So her albumin is 3, pre-albumin is 10, and she got a CT scan, and it looks the same as the last one. There's no abscess, but it's inflamed, and there's an enterovaginal fistula.
Okay. I think with this patient, I would want to start her on fluid resuscitation and would consider parenteral nutrition, given her low albumin and pre-albumin, and then discuss with her diverting ileostomy to allow this to recover prior to any definitive surgical intervention.
Okay. So are you doing this outpatient, inpatient?
So I would admit her from the ED to do this.
And anything else you want to do regarding her output, her raw perineum?
I would consult my wound ostomy nurses for assistance with management with that. I would expect them to utilize barrier creams to help, and then also again would expect the diverting stoma to help better control her fecal stream, and they would also be able to preoperatively mark her so that the stoma is placed in a good position.
And so let's say you do that, you divert her, you get her on TPN, and she gets better. The output goes down because she's no longer eating. She has barrier ointments. Her skin is getting better. It's let's say it's been about 5-7 days. She's ready for the next step. She wants to know what's next.
So I think given the degree of inflammation and malnutrition, I would want to discharge her from the hospital and plan to wait several months for that inflammation to resolve prior to further assessment for potential definitive surgical intervention.
Okay, now let's say the inflammation goes down. She's feeling better. She's been on TPN for more than 6-8 weeks, and her albumin's better. How are you going to manage this fistula?
Yeah, so I'd want to confirm that she still has a fistula with contrast thread through the distal limb of the diverting loop ileostomy, and as well as considering an MRI to better characterize it.
Okay. Let's say it all looks the same on the imaging. What operation are you taking her for?
So I would plan to take her again for exploratory laparotomy, small bowel resection. Again, want to have my gynecologic colleagues there. Given the degree of inflammation, would also ask my urology colleagues to place stents preoperative to make identification of the ureters and any potential ureter injury more easier.
Great. So, I think that's good there. We can end there. I think overall you did a pretty good job. I don't know if you've had this case yet yourself yet, but this is actually a case of mine. And I didn't actually divert, but I did. And it just initially she had low output fistula. Eventually it became a high output, and I took her and resected the bowel and the pelvis, and had to do another anastomosis, but she had no other disease. I did have a ureteral stent. Luckily, I was able to leave the vagina alone, and I did place some momentum in that area, and she did well with no signs of recurrence. Some of the things I think making sure you consult urology for the first time too, just to get that stent, because the pelvis is going to be a mess, and talking about possible vaginal surgery, having gyne involved if they're available, and optimizing the patient ahead of time. So it took some prompting, but you can kind of relate it to enteroatmospheric fistulas. Besides assessing whether or not they're septic, that they need to be resuscitated, the local wound care part is huge, and the perineum is more difficult. It's harder to make an ostomy around there, especially if they have urethra. You basically can't, not that I know of, but barrier ointments can help. Phil, have you had any experience like this, or any other input you want to add?
I thought this was a case that you saw at county at one time, but I think also the other ways that you may turn this scenario around is basically if it continued to still be high output, all right, you may be concerned of a much more proximal fistula, which you may not be able to divert, and you may have to work with different agents to sort of do that. So basically it's very similar to high output ileostomy, which is a very common situation too, that you may run into a board scenario or hotel room or Zoom scenario too as well. So looking at that, maybe even going up to like the aspects of maybe even somatostatin or other sort of interventional agents too as well. And such. Some people may also talk about clipping in these sort of scenarios, especially intervaginally, unless you have a lot of experience with it. Don't go down that route unless you do have some experience, because it could lead you down the wrong way, and you may actually find some colorectal surgeons that do clip things and everything. This is probably not the scenario, but basically, if it was the last option or something like that, or if they're a very frail patient or something or other, maybe that might be in your wheelhouse, but I wouldn't mention it too. So just keep it out of your mind. But some people have mentioned it in these board scenarios too as well. I think I don't know if we do have enough time for another one, but one that also does get asked and does show up is a functional GI disorders. Okay, constipation especially. As far as a question, do you guys want to hear like there's my son. Do you guys want to hear like a little quick sample and wants to try to take? Alrighty. So it's a 76-year-old female who basically presents with what she says is constipation for her entire lifetime. She's tried a whole host of different agents, stool softeners, laxatives. Her current regimen consists of basically Senna 3 times a day, Miralax twice a day on a daily basis. She's tried Linzess and other pro-motility agents, but reports that she just gets way too much distension and irritation and abdominal discomfort associated with it. No prior colon surgeries or abdominal surgeries, except for actually 3 C-sections and a hysterectomy. Okay, sorry. And also she's had a colonoscopy. Her last colonoscopy was at the ripe age of 75, which basically was nothing was seen, essentially normal. She comes to you because basically she heard through the grapevine from your gastroenterologist, you are the person to see. because you can't poop. Who wants to take that on? All right, Dr. Modi, what would you do?
I'd like a little bit more history about her diet, what she takes. Ask her about her bowel movements. You already gave me the history about what she has tried in the past. I will also review the colonoscopy findings, and then I'll do and also ask her some family history and do a focused physical exam, focusing on the abdomen and the anorectal exam. Especially on the anorectal exam, I'm trying to look for the sphincters, Valsalva maneuver, any signs of dyssynergia, perineal body, and any rectal seed.
Okay, so she says that she spends about 1 hour on the toilet to have a bowel movement. Her bowel movements are fairly firm and formed. She denies any episodes of diarrhea. She has a bowel movement approximately 1 every 7 days on this regimen. But she says that it was way worse when she was not on this regimen. She would have like a bowel movement once every 2 weeks. Her diet, she reports that, she's gradually becoming food intolerant because basically whenever she eats something, she would get a lot of distension. It just takes a long time for everything to go through. She does report that she's had prior sort of workups for quote unquote dysmotility, but that was probably when she was in her 40s and 50s, and she just has been ignoring it since then because life happens and she hasn't gotten anybody that was patient enough to see her. Let's see what else. So in regards to her diet, she says that she does drink about 2 liters of water. She does take fiber in her diet, but like she said, it does result in sometimes some moderate distension. So basically, she thinks she takes about like 1,100 calories per day, and she has lost around 30 pounds in regards to that.
Okay, perfect. I will also review her history of her medicines, what medical problems she has, and what medicines she takes currently at this time, to see if any of these can cause constipation.
She has a history of low back pain, for which she takes NSAIDs for, mainly Motrin. On occasion, she does take oxycodone once every week. And she has a history of hypothyroidism, for which she takes levothyroxine 125 micrograms daily basis.
Okay, so at this time I forgot the age.
76.
A 76-year-old female who recently had a colonoscopy, which was normal. I've reviewed, who is hypothyroid, has tried multiple medical therapies for her, looks like constipation, and she has recent weight loss of 30 pounds as well. So I will send some labs from the clinic, CBC, CMP, thyroid function panel, a CRP as well. Again, I will also counsel her for a repeat scope just because she has recently lost weight, and also get a CT scan of abdomen pelvis with oral and IV contrast and see what that shows. And also, I had did an anorectal exam, which I didn't get the findings for. Sorry.
Oh, sure. Anorectal exam demonstrates some mild skin tags, normal, maybe slightly increased anal tone, no mass is palpable, no pain on palpation of the perineal wall, no evidence of prior surgery. On Valsalva, you do note that she does have a perineal descent of about 1.5 to 2 centimeters, but no evidence of pelvic organ prolapse. Okay. No evacuation of urine, and essentially no evidence of incontinence, no patchlessness of the anus during Valsalva as well. So how do you work this patient up? Oh, sorry. So you got all those labs. Okay. Basically shows she's no more thyroid, she's euthyroid, calcium levels within normal limits, nothing noted on the electrolytes, potassium is 4. And let's see, CT scan demonstrates mildly dilated colon throughout, no masses appreciated within there, no small bowel dilation. Basically unremarkable colon, maybe a mild fatty liver, and you schedule her for a colonoscopy, which confirms basically she has some moderate amount of retained stool with your prep, but otherwise no evidence of large adenomas or colon cancer noted. How would you like to proceed?
So number one, regarding colonoscopy, I will counsel her to get a repeat colonoscopy with a 2-day prep after a year or 6 months, just to cover her bases. In the meantime, I also get a cyst marker study for colonic motility, see what's the distribution of those markers, a Senate echography to see the evacuation, or look for any other pelvic organ prolapse, and also anorectal manometry. to see if there is any signs of pelvic dyssynergia or a rectal hypersensitivity.
Kindly repeat to me, how would you evaluate for pelvic organ prolapse again in regards to the study? You said SITS marker and a
Synedefocography.
synedefocography. Okay.
Yeah. So look for the evacuation and other organ prolapses. They will give contrast into the vagina and also the bladder.
Very good. So you do a SITS marker study, which basically shows on day one. What days do you take your x-rays for your SITS marker?
Day 1 and day 5.
Okay, so on day one, basically it shows that all the SITS markers are within the right colon. On day 5, it demonstrates that there are 16 of 24 markers within the area of the rectosigmoid colon. Moderate stool burden, but otherwise, she followed her instructions in regard. She was off of all the laxatives or bowel agents during that time. You do synedefocography, basically, which shows a anterior rectocele of about 3 centimeters with a mild rectal intussusception. Okay, she does evacuate about 80% of the contrast within her rectum. And basically the contrast in her vagina basically just evacuates out with the Valsalva, and no evidence of enterocele or cystocele on that study too as well. But the rectal intussusception is without rectal prolapse and extends all the way up to the level of the levators. Also confirms another 2 centimeter descent from the Z line, and also with squeeze. Basically, what they note too, during Valsalva, it took about 20 minutes for her to relax the anal sphincter. So they noted some abnormal paradoxical anal squeeze with the initial attempt with Valsalva, and then she was able to relax afterwards after a long period of sitting on the commode. How would you counsel this patient?
So this is a 78-year-old female who has got rectal intussusception, SITS marker at the rectosigmoid junction, and also abnormal relaxation of the paradoxical contraction of the puborectalis muscle. So I will first send this patient for pelvic floor therapy for biofeedback, so we can train the pelvic dyssynergia, and I will see her back in 3 months. In the meantime, I'll keep her on the bowel regimen she's on and counsel her to take fiber and laxatives.
She heard online about the role of basically, you told her it's abnormal relaxation of the sphincter muscle. What is your role in regards to Botox?
I'm not sure, sir. I'm not done the Botox in my practice for abnormal relaxation. I've done first pelvic floor therapy, and then I've proceeded to see how they do.
Okay. So she comes after you in 6 months saying that she does have some mildly improved bowel function. She spends now about 30 minutes on the toilet. How else would you like to proceed?
Yeah, I'll redo the anorectal manometry, see if that the function, the dyssynergic paradoxical contraction has improved, and go from there. If that has improved, then I have the surgical plan for her rectal intussusception and the rectosigmoid area where the SITS markers were being collected by simulating.
Okay. I think that does conclude our time, but yeah, you could see that scenario could blossom to a lot of different sort of things. Okay. And I've had that also blossom to the form of basically you do the physical therapy, and then she goes on to fecal incontinence and such. It can go on to colostomy. They keep pushing it and everything, but I think it's more of like the counseling. You have to counsel these patients that this is a long-term sort of thing. It takes time for it to resolve. I tell them quite often, it took you 76 years to, get to this point. It might take 76 years to get back. I mean, not necessarily 76 years, but a long time to get back.
Yeah, my idea was to just first fix the paradoxical contraction so it doesn't cause problem, then do a resection rectopexy, and I'll remove the rectosigmoid area and also pull up the rectum either by suture or I'll apply a biologic mesh.
The other thing I would probably mention is stool diary, and then also basically the reintroduction of newer you may have to be more facile on identifying the types of bowel regimen stimulants. Okay, not just Linzess. Okay, there's like Mobic and Amitiza and things, and depending on what they're on and medication and stuff like that, you should sort of go over with. But yeah, physical therapy. The other thing I didn't mention on colonoscopy is the solitary rectal ulcer syndrome. They won't call it solitary rectal ulcer. They'll probably say there's an ulcer and it's biopsied and it shows basically like hyalinization and stuff like that in the lamina propria, all those sort of things.
Yes,
Okay,
sir.
so call it what it is. But yeah,
Would you mind telling me about the Botox on that sphincters? Never done that for that purpose, so I want to know how it is.
yeah, no, it's just basically they will throw a scenario. The data on it is very fluffy. Okay.
I have not done it,
And
so I didn't know, so I didn't want to do it. If that didn't work, I was gonna give a loop ileostomy just for relieve her symptoms for a while and then keep working on the rest of the stuff.
that would be the way. Just realize when you do the loop ileostomy, you have no other way of evaluating their bowel function sort of afterwards. So
Yeah.
that's just the limitation of it, and that might be brought up as a discussion. But as long as you kind of go over like the risks and benefits of your procedures, I think you'll probably pass that scenario. But a lot of people do get flustered because they haven't heard a scenario in regards to functional constipation. And I think that's something that you guys should prepare yourself. And then anal fistulas. I think we were planning to do it, but I think for lack of time, Jason and I, we decided to hit something that we're just a little bit harder to hit, so to speak. So hopefully you guys got something from this.
Thank you. I really appreciate you guys taking your time and then pimping us, basically. I like it.
Yeah, I think I kind of threw off Dr. Peroni a little bit if you haven't seen these kind of enterovaginal fistulas, but to remember your basics of like how you would apply treatment of an enteroatmospheric enterocutaneous fistula. And regarding clipping, I've never seen that work. Everything was rock hard. This is a radiation related prior infection, fibrotic reason for fistula formation. So make sure to know your reasons for why fistulas form. She had a chronic partial obstruction, radiation in the past. But also to be mindful, I think you were careful to think about, is this a recurrent cancer? It can always be. And for this lady, this actual case, it was not. Had biopsies done and nothing was cancer. Any questions regarding any of the scenarios?
We have a couple audience questions, if Dr. Chen, Dr. Dudala, if you guys have the time.
Sure.
The first one was the first two are regarding the first scenario. And so Dr. Squilero on Surgeon asked, can you review the options again for that cecal serosal tear in this scenario?
So I had a question similar to this, I believe, when I took the test, and I missed it, and I thought because some mild serosal tears could be left alone, but I didn't pass that part of the exam, and I think they were going for subtotal colectomy or right colectomy, and I think either one is reasonable. I think in my practice now, I probably would have just done a subtotal if somebody's malnourished. I'm trying to do less. I think less is more in terms of having anastomoses. So if you have a obstructing left-sided cancer and your cecum looks terrible or compromised, I prefer doing a subtotal colectomy and ileostomy and then doing reconstruction later, just getting out. If you did a right colectomy and left colectomy, and then you did a ileocolonic anastomosis and a or colorectal anastomosis and divert upstream, and all those take time. A sick patient, I think less is more. Phil, what would you have done in that scenario?
Yeah, so you do have to treat the cecum. And the justification also for subtotal is basically you don't have any other way to you don't know what the rest of his colon looks like, sort of thing, right? I mean, less invasive surgery, technically you would say, oh, a right and a left would still preserve the colon. But like you said, depending on the scenario of the patient, whether they're stable or not, may push you to basically do something more urgent as opposed to that and have to sort of talk to the patient about it. The other is basically doing a diversion. I think like you mentioned, Dr. Modi, like much more proximal to that after doing the colectomy and sort of just fighting your battles later. In regards, that's also an option. Either is fine as long as you have the sort of thought about it and don't flounder about it, sort of thing. But leaving it alone typically in that sort of scenario may get you the eye wrinkle. And you could always, if you see that and you looked at it you see that in the examiner, and you're like, oh, hold on, let me just say this instead. They won't fault you on it, okay? Because basically, they know it's a high stress sort of situation. Okay, just you could come back and like recover as long as you recover immediately. Don't recover later. Okay.
Dr. Dulac asks, also regarding the first scenario, is it wrong to attempt stent in the initial scenario with the sigmoid mass since patient is stable?
So, I think it's an option. But this is somebody with a concern for a liver met that's going to need chemo. And if you're going to stent somebody, usually I think of stenting as a bridge to surgery, that you're going to get them through this emergent admission so that they can pass some stool into a bowel prep and then resect. That's how I usually think of stenting as somebody I plan to resect. But somebody I think has metastatic disease and needs chemo, I'd rather resect, bring up an encolostomy, and not worry about any kind of anastomosis. And then they can tolerate chemo. Um, if you stent, there's concern for perforation, migration, pain. If you're gonna do chemo for 3 to 4 months, it can easily perforate, migrate during that time.
And if it was not metastatic disease and you decide to do stent, then it's going to open up the other series of questions, okay, which is how do you assess whether this patient's appropriate for stent? Is it at a bend? Is it a straight path? Do you have your fluoro license? How would you set this patient up in the procedure? All those sort of things. Like I said, if you don't have a lot of experience doing stents, uh, you can mention it as an option, but not like something that you would necessarily sort of pursue and everything. And I think do what you feel is safe in your practice. I mean, you guys have the luxury of been practicing out for a while now, so try do what you think is like with your sort of own resources because you're already very familiar with that answer. Yeah. Okay.
I do have a question since going on the stent. If I do my own cystoscopy and ureteral stenting, can I just say that? Because I do all my own. So I just want to know, is it okay? Like, or do I need to get urology involved right from the first case? Like right from for prophylactic stenting, not when there is actual injury.
It's reasonable if you know how to describe it, you can say it, but I don't. So in my practice, I refer to urology because I wouldn't know how to describe all the steps and how to troubleshoot.
Exactly. And as long as you know also how to consent the patient for that too as well. And it wouldn't be a bad thing that says if I had the injury, I'd still do what I do, but then also call my urology colleagues.
No, I was talking
Yeah.
about the prophylactic stenting, like before the case. I can say I put my own stents, do a stent with the stents, but not when the injury happens. When injury happens, we are supposed to say that urology will be called.
Yeah.
But for the initial part,
you could do it as long as you know it. Okay.
Yeah.
As long as you have the verbiage and confidence to show that, then that's fine.
All right, thanks.
It's the same also for the lateral pelvic lymph node dissection. Okay, for rectal cancer. If you know how to do it, then go right ahead. Just start saying it. Okay. But if not, then you got to call for help. The other scenario too that you're going to run into, we did a colon cancer scenario. You will run into a watch and wait or organ preservation in rectal cancer scenario. Okay, so look how you know how you discuss that. Okay, and how you determine the question where they be is like, what's your follow up after seeing these patients? Okay, you got to know that they will the recurrences 98% of the time will happen within the first 3 years. So you got to be very close surveillance. Whether you choose the Haber Gamma every 1 month sort of physical exam sort of thing, or you go the more sort of modern Memorial Sloan Kettering way, which is like every 3 months, patients assessed by you with MRIs or flexible sigmoidoscopies and physical exams. Okay, or more frequent physical exams, depending if they have symptoms with bleeding or changing bowel habits too as well. Okay.
One last question from the chat. This is regarding the second scenario on the bladder repair. If urology not available, do you need to say perform in 2 layers or okay to perform in 1 layer if small? And that's from Dr. Murphy.
I err on 2 layers. 2 layers has basically been the board answer even for my general surgery exam. The only time that I'd probably say, 1 layer is maybe if you did the bladder distension and you do the cystogram, the retrograde cystogram, and there's no leak, and it was a really small, or you didn't find even the hole, like sort of thing. You want to just over repair the rent that you have, but I think the classic answer has been 2 layers, especially if you see bladder mucosa.
Yeah, I would do the same and get a CT cysto afterwards, 2 weeks, leave a Foley and decompress and make sure there's no extra. And get urology involved in outpatient. If there's extra, leave the Foley in for longer, repeat a CT cysto again in 2 more weeks to see if it's resolved.
Thank you so much. Thank you so much to Dr. Chen, Dr. Doodle for bringing those scenarios to us and being willing to be our examiners. And I want to say thank you again to Dr. Modi, Dr. Peroni, Dr. Pierre for taking your time and being willing to be examined. I hope this session was useful for all of you and also for our audience. Just to be respectful of everyone's time, I think that we'll conclude the session for now. Are there any other last minute comments or questions?
Thank you.
Thank you, everyone. Have a great evening.
Good luck, everyone.